Now we're briefly going to look at gynecologic procedures. We will talk about each of these in more detail in the sections which are more specific, but this is to give you a general overall feel. Starting out with gynecologic ultrasound. This imaging modality uses low-energy, high-frequency sound waves. Sometimes it is called sono, sometimes it is called sonography, but it is basically the same. It works in a same fashion as radar. Transvaginal transducers can be used, or transabdominal transducers. The transvaginal transducers have advantages in that they produce high-resolution images irrespective of the abdominal wall thickness of the mother. The limitation is that you can only look at lower pelvic masses because of the short focal length. Basically, ultrasound has a trade-off between resolution, and the shorter the focal length, the higher the resolution. The longer the focal length, the lower the resolution. The transabdominal transducers can image the entire pelvis as well as the abdomen, but are limited because you have a longer focal length but lower resolution. Ultrasound works best when adjacent tissues have differing echo densities, particularly fluid tissue interfaces. If you have fluid and then you have the tissue, that junction gives you the best ultrasound detail. This image shows transvaginal ultrasound, and the probe is placed through the vagina, and you can see how it has a pie-shaped image. That is classic for the transvaginal ultrasound. And you can see how it will insonate the pelvic structures and will give you images of unparalleled quality. By rotating the transducer, you can go from anterior-posterior view to a transverse view. This is very helpful when assessing pelvic masses. All right, the next procedure we'll look at is cervical pap smear. Now, we'll talk more about this in the chapter on cervical neoplasia. Cervical pap smear is an outpatient screening procedure for premalignant cervical changes, allowing for early intervention to prevent cervical cancer. Frankly, the whole point of a pap smear is to prevent cervical cancer, not necessarily to identify premalignant changes, because some women with the cervical dysplasia will never progress to cervical cancer. There is an involution which occurs spontaneously. We'll talk about that more later. The pap smear requires 2 specimens, and these are cytologic specimens. The cytologic looks at the cell morphology, not the histology. So these are scrapings of the external layers of the cervix. The area that we're particularly interested in is the transformation zone, also known as the T-zone. The external cervix, or ectocervix, is scraped using a wooden or plastic spatula, rotated against the surface of the transformation zone. I'll show you what that looks like. Then we obtain samples of the endocervical canal. The endocervical canal is columnar epithelium, whereas the external or ectocervix is squamous epithelium. We use a brush or cotton tip applicator in pregnancy to obtain the endocervical cells. So it's important to get both of these. The traditional pap smear specimens are obtained using a spatula and brush, which we just talked about. The cells are smeared onto a glass slide, which are then fixed in formalin, stained, and examined under microscope by a cytologist. I'll show you these pictures in just a moment. The newer method uses a liquid-based pap smear. We still obtain the specimens using the spatula and brush, but instead of smearing them onto a glass slide, they are shaken in a formalin solution, and the advantage is that you shake off, hopefully, all of the cells, and you don't discard them as can happen with the collecting instrument. So advantage of the liquid-based pap smear is air drying artifacts are less likely because you immediately put it into the solution. The cells are spread more evenly on the glass slide surface, and I'll show you what that looks like, thus minimizing unsatisfactory readings, such as ascus, atypical squamous cells of uncertain significance. All right, let's look at the cytological screening of the transformation zone. This is the cervix as you would see it through the vagina, through a speculum, on a girl who is just entering adolescence. The pink area is the stratified squamous epithelium. The dark area is the endocervical canal, and the red area is columnar epithelium, which has been stretched out from the endocervical canal over the ectocervix. This area here, between the pink and the red, is called the squamocolumnar junction. And we will call this the old squamocolumnar junction because it's going to move from here to here. What will happen with exposure of the columnar epithelium to the acidic vagina of the estrogen-dominant adolescent girl, we're going to see a metaplasia of this columnar epithelium, and notice what happens. The squamocolumnar junction moves from here to here. Let me show you that again. It moves from the outer to the inner. This area between the two squamocolumnar junctions, the old and the new, is changed by metaplasia into squamous epithelium. Did you see that? Let me show it to you again. This area then, which is hatched, is what is called the transformation zone. And why is this important? Because 95% of cervical neoplasia and cancer develops on the transformation zone. When you do your pap smear, it is important, essential, that you sample the transformation zone. When you look with colposcopy, which we'll look at in just a moment, it is important to assess visually the transformation zone. So the old squamocolumnar junction, the new squamocolumnar junction. Here we have a picture of a cervix, and you can see the stratified squamous epithelium, which is here. And you can see here is the columnar epithelium, which is more of a reddish color. The transformation zone is around the edges here. All right, the two specimens. We use a spatula to obtain the ectocervical specimen. This is done the same way in pregnancy or in the non-pregnant. And here you can see with a sagittal view, we obtain the specimen by rotating the spatula. The endocervical specimen is obtained in the non-pregnant patient with a brush, and with the pregnant patient, we're going to use a cotton tip applicator because we want to minimize the bleeding. You can see here is the new squamocolumnar junction. This is the stratified squamous of the ectocervix. This is the columnar epithelium of the endocervical canal. In the conventional pap smear, these are then smeared onto a glass slide like this, and then we will either put the glass slide into formalin or we will spray it with hairspray. Basically, we're fixing the specimen. We are wanting to avoid air drying. However, if you wait and if you don't spray right away, you can get air drying, and that's one of the limitations of the conventional pap smear. You can see here the red represents abnormal cells. We smear it onto the slide, but do all the cells come off? They may not, and we may actually throw abnormal cells into the garbage because we discard it with the specimen collector. So you have potentially a false negative pap smear. The other limitation of the conventional pap smear is as you smear, you can get cells which are on top of each other. And you can see on here, it's going to be very difficult to examine the morphology of the cells. Now, this is, of course, the worst looking specimen you could get, but it does highlight the limitations. The liquid-based pap smear is different. Instead of smearing onto a glass slide, you rinse the specimens into a preserving solution. And here is the brush, here is a spatula, here is endocervical specimen, and we rinse it into a preserving solution, like this. And the idea is that all of these cells will come off, and then they will be suspended and put evenly onto a glass slide. Notice the difference between the conventional pap smear and the liquid-based. You do not have these slides which are on top of each other. And that will then allow for more accurate reading. The advantages of liquid-based pap smear is you have a monolayer of cells rather than multi-layers. You eliminate air drying because you shake the specimen into the formalin. And this is a major advantage. If you have an ascus, atypical squamous cells of uncertain significance, you can do HPV DNA typing on the residual which is left in this solution, and you can then look to see if you have a 16 and 18 HPV or a 611. The 16 and 18 is at high risk for cervical cancer. The 6 and 11 is not. Colposcopy. If you have an abnormal pap smear, which is atypical squamous cells of high risk, or if you have CIN, LSIL, HSIL, or cancer, you must do a colposcopy. A colposcopy is an outpatient office procedure which uses a binocular, that means you look with both eyes, short focal length instrument. It's like a pair of binoculars, but it's short focal length. It has a built-in light source which sends the light through the speculum, through the vagina, and we can look at the cervix. The exocervix is visually examined to localize areas of abnormal epithelium. Those abnormal areas include punctation, mosaicism, white epithelium abnormal vessels. We'll talk about that later on. And those will be then biopsied and sent to the pathologist for a histological assessment rather than a cytological. Okay, here we have a colposcope. You can see it's a binocular instrument. This is the light source. The patient is placed in stirrups, speculum is placed in the vagina, and now you can look in and visualize the surface of the ectocervix. The whole point is to look for these abnormal areas, a white epithelium, punctation, mosaicism, or abnormal vessels, and to do a biopsy. Here you can see the light source is coming through into the vagina, and we can view the cervix. So colpo is vagina, oscopy is looking in. We're looking into the vagina. When we look with the colposcope, we want to look to see, is the transformation zone with or without any lesions? This is the old squamous columnar junction, this is the new squamous columnar junction, and this is the area that we have an interest in. Firstly, does the squamous epithelium extend into the canal? And you can see here it doesn't. This is called a satisfactory colposcopy. The transformation zone epithelium does not enter into the endocervical canal. Now compare that with the next picture. Here you can see some stratified squamous epithelium. It's normal in appearance. There's no white epithelium, no mosaicism, no punctation, but it goes into the canal. And you don't know how far it goes into the canal. So we call this an unsatisfactory colposcopy. And we'll talk more about this later. Cone biopsy. The cone biopsy is also known as a cold knife cone biopsy because it uses a scalpel rather than a hot wire, which is the LEEP. This is an outpatient surgical procedure performed in the operating room. So it's not done in the office under either local or general anesthesia. A cone-shaped tissue specimen is obtained with a scalpel. So you can have bleeding, performed by a circumferential incision of the cervix with a wider diameter at the cervical os, narrowing as the endocervical canal is approached. Did you understand those words? A picture is worth 1,000 words. We'll look at a picture in just a minute. We can either do a wide, shallow cone, and you'll see this is done if the pap smear is worse than the colposcopically directed biopsy. If you don't know where the lesion came from, you basically excise the entire exocervix. Or you can do a narrow, deep cone if a lesion extends from the exocervix into the endocervical canal, and we send this then to the pathologist. Are there long-term risks? Yes, there are. We'll talk about that. Here you can see is the exocervix, and here is a lesion. Now they're not green, you understand that? This is just for instructional purposes. Now when you're looking through the vagina here, how far does this green go into the canal? You don't know. You can't see. So what you will need to do is a cone biopsy. You will cut out a section like this, which is narrow in the proximal end, wider in the distal end. You can see how this looks like a cone. Ice cream cone, whatever you want to call it. Are there risks? Yes, we just talked about that. Incompetent cervix, if you cut out too much of the stroma, or failure in healing, we call that cervical stenosis, and this can cause secondary amenorrhea. We'll talk about that later on. LEEP. LEEP stands for Loop Electrosurgical Excision Procedure. This is done in association with colposcopy. An outpatient office procedure, not in the operating room, in the office, performed without anesthesia. A thin, low-voltage electrified wire loop cuts out abnormal cervical tissue identified with colposcopy. So you see these abnormal areas, and you can then resect them and send them to pathology using the LEEP. The advantage, when you see an abnormal area, you can confirm visually that the abnormal tissue is gone. And that is different from the cryotherapy, where you don't know if it's been removed because you freeze it. Then you can take the tissue specimen, send it for histological diagnosis, and the pathologist will tell you what is the nature of the lesion, did you get it all out, are the margins clear. Anytime you do a LEEP, you must do follow-up pap smears every 3 to 6 months for a couple of years before you can say that there's no recurrence. This is the instruments that you use. You can see they have wire loops of different sizes. An electrical current comes from this end down here and makes the loop hot. Then, like a cheese slicer, you can slice away the tissue and you can send it to pathology. You can see this is a shallow but a wide cone. Cryotherapy. Cryo means cold, and we are going to freeze the cervix. It's an outpatient office procedure performed without anesthesia. It is similar in that respect to the LEEP. Liquid nitrogen or carbon dioxide circulates through the probe placed against the cervix. I'll show you what that looks like. And it lowers the temperature of the probe to 100 degrees below zero. Very, very cold. This freezes the tissue for 2 to 3 minutes and creates what is called an ice ball. You can then thaw it and then refreeze it for another 2 to 3 minutes. Or you could use a single freeze for 5 minutes. What do you think this does to the cervical tissue? It destroys it. That's the whole point. It causes it to die, and what will happen then in the next few weeks? A watery vaginal discharge as all of this is shedding off. Now, do you know that you've destroyed the tissue? You really don't know because you haven't taken it out. You're hoping that it will slough off. But the only way you can know for sure is you do repeat pap smears every 3 to 6 months for a couple of years, just like you did with the LEEP. Okay, this slide shows the sagittal view of the cervix and the vagina. Here's the vagina down here. This is the cervix. This is on one side, this is the other side, this is the cervical canal. And let's imagine that these brown areas here are the abnormal areas that we want to destroy. What we will do is to bring our probe and place it against the cervix. We will lower the temperature of this and create an ice ball. And what happens then is this area is going to freeze. Now you can see that what we want to do is to destroy this area, which hopefully it will, but you also will destroy some normal tissue as well. And that's just one of the limitations of the cryotherapy. It is an outpatient procedure, requires no anesthesia, and that's the advantage. But you've got to do follow-up pap smears. Okay, the next procedure we'll talk about is hysterectomy. This is a major surgery. This is inpatient procedure performed in the operating room under either regional or general anesthesia. It can be used for both diagnosis as well as therapy. We'll be talking about this in many different ways. The whole purpose of the hysterectomy is to remove the uterus or the hyster. Historically, women who were hysterical were thought to have a problem with the uterus, and the uterus is what caused their hysteria. We know that is no longer true. Hysterectomy. We're going to ectomize the hyster. Depending on the indications and the pelvic exam, the procedure can be either performed vaginally or abdominally. If a woman has had children, if there is some uterine prolapse, a vaginal hysterectomy can be done very nicely with less morbidity. Or abdominal procedure depending on what the purpose. If you're going to do a radical hysterectomy, you must do it abdominally. There's various kinds of hysterectomies that one can do. You can do a subtotal hysterectomy. And this is done when I was in China some years ago. Most commonly, a subtotal hysterectomy was done. Removes only the corpus of the uterus, leaves the cervix in place, and the reason for this, it was felt that sexual functioning would be enhanced by leaving the cervix in place. In the United States, that is not the belief, and the cervix is usually taken out as well. The subtotal hysterectomy may be done if you have, for instance, the corpus of the uterus is enlarged because of leiomyomas or adenomyosis. And technically, it is difficult to take the cervix out. If you take out the corpus but leave the cervix in, the cervix doesn't know, of course, that the corpus has gone out and still is at risk for cervical cancer. So pap smears still will need to be done. A total hysterectomy, which is the most common procedure in the United States, removes both the corpus and the cervix of the uterus. If you remove the cervix, there is obviously no risk of cervical cancer, so no pap smears need to be done if this was done for benign purposes. Now, if you take out the cervix or do a total hysterectomy for cervical cancer, that's a different story. A radical hysterectomy is where you take out not only the corpus of the uterus and the cervix, but also you remove the broad ligament. This would be done if you are concerned about metastasis to the pelvic lymph nodes with cervical cancer. Okay, so here we have the uterus, the ovaries, and the fallopian tubes. If you do a subtotal hysterectomy, this is what is taken out. The corpus of the uterus only, the cervix is left in place. This is a subtotal hysterectomy. Pap smears need to be continued. If you do a total hysterectomy, you leave the ovaries and tubes, you take out the corpus of the uterus and the cervix. You can see you have to close the vagina then, because you have no cervix, which is distal to it. If we do a unilateral salpingo-oophorectomy, we will remove the tube and ovary on one side only. If we do a bilateral salpingo-oophorectomy, we will take out both tubes and ovaries and leave the uterus and cervix in place. This is rarely done unless there are significant adhesions and in vitro fertilization is going to be performed. If we do a total abdominal hysterectomy, bilateral salpingo-oophorectomy, and this is done with all endometrial carcinomas, what we will do is both tubes and ovaries, the corpus of the uterus, and the cervix. And this is total abdominal hysterectomy, bilateral salpingo-oophorectomy, and this can be abbreviated to TAH-BSO. You'll hear me talking about that as we go through the chapters. Hysteroscopy is looking inside the uterus. Oscopy, looking in, hyster, uterus. This is an outpatient procedure performed in the operating room typically under either local, intravenous, or general anesthesia. You can use it for both diagnosis and therapy. A fiber optic scope is placed through the previously dilated cervix, and you directly visualize the endometrial cavity. A clear, high molecular weight dextran viscous fluid is infused through the side ports of the scope to distend the uterine cavity, allowing visualization. Otherwise, the walls of the uterus will come together and you won't be able to see anything. So we use a dextran, which we will place into the uterus. Other side ports can be used to place instruments, to biopsy lesions, resect submucous leiomyomas, polyps, or uterine septa, and we'll see how this is done later on. This is a hysteroscope. This is where you look inside, and you can see we have different ports here, here, or here. So this is placed through the cervix into the uterine cavity. You can put this into a TV monitor so more than one person can look at it, and you can do a variety of different procedures. Hysteroscopy. You can see how the uterine cavity is distended with a dextran, and then you can use a loop electrode to obtain a biopsy or to resect submucous leiomyomas, and I'll show you some video of that later on. Laparoscopy, oscopy, is looking into the abdominal pelvic cavity. This is a minor outpatient surgical procedure performed in the operating room under general anesthesia. And the reason you use general anesthesia is because you want to get good relaxation of the abdominal wall. You can use this for diagnosis, and we'll talk about that in just a minute, as well as therapy if you're going to be resecting or removing organs. The pelvic abdominal cavity is insufflated or distended with pressurized carbon dioxide. It distends the abdomen and lifts the abdominal wall away from the viscera, so when you put in your instruments, you're not going to perforate into vessels or organs. A fiber optic scope is then placed through a port, which is placed through the umbilicus. This is typically where we place it, to visualize and to examine the pelvis and abdomen. This is used for general surgery for removing organs such as the gallbladder. In gynecology, we will use it for both diagnosing and treating causes of chronic pelvic pain. We'll talk about this at some length. Endometriosis, adhesions from chronic PID. If you have an advanced ectopic pregnancy, you can remove that using a laparoscopy. And if there are adhesions of the tube, of the fimbria with infertility, you can use laparoscopy as well. And here you can see the scope, which illuminates. You can see how the abdominal wall is extended away from the viscera, and then you can use various ports to do your procedures. Hysterosalpingogram, which is often abbreviated to HSG, is an outpatient diagnostic radiologic imaging procedure performed without anesthesia. A cannula is placed in the endocervical canal, and radio-opaque fluid is injected into the uterine cavity, allowing assessment of the uterine malformations, which may be there, uterine septum, bicornuate uterus, or whatever. Also, the dye goes in through the uterine cavity into the tube, and you can observe the tubal anatomy to see if there's any pathology. Also, is the opening from the tube at the fimbria, is it patent? Will dye spill into the pelvic cavity? Here we can see is a picture of hysterosalpingogram. Here the device is placed in the endocervical canal, and we put in the dye. You can see we have a nice triangular shaped uterine cavity. Now what happens? This goes through the proximal tube, through the distal tube, and it spills into the peritoneal cavity. This is a normal appearing tube. I like it. How about the other side? You can see this side fills, but the dye does not spill because the distal end of the tube is occluded. Here we have an abnormal tube. So we can assess the uterine cavity, we can assess the proximal, the distal tube. And here is a nice triangular shaped uterine cavity. You can see there is a very thin proximal tube on both sides, and here you can see the distal tube and the spillage which goes into the cavity, pelvic cavity. And that's normal. This is a normal hysterosalpingogram. Dilation and curettage. This is done for procedures which want to either diagnose or, actually most of them are diagnostic procedures. This is an outpatient surgical procedure performed under anesthesia. It can be either local, intravenous, or general anesthesia, and it is done in the operating room because it can be painful. The cervix is dilated with cervical dilators prior to introduction of the curette. I'll show you that in a minute. The curette is used to scrape the endometrium to obtain larger amounts of endometrial tissue than you would get with an endometrial biopsy. You send the tissue to pathology for assessment for histology. Is it abnormal or normal? This is metal dilators. This is done for a minimal procedure. This is done if you want to dilate the cervix more. This is the instrument which is used to scrape the uterine cavity. This is called a curette, a sharp curette. This will take a specimen of the endometrial lining. And here you can see how it is placed into the uterus and is then pulled backward and removes the specimen. Endometrial biopsy. This is an outpatient office procedure. And this is often performed either without anesthesia or with topical anesthesia placed on the cervix. It is a diagnostic test looking at the histology of endometrial lesions. The most common reason for this is postmenopausal bleeding. We'll talk about that later. You want to identify the direction of the cervical canal with a uterine sound, and you've identified where the uterine cavity is. And this then will help you as you place your cannula. A hollow suction cannula is then placed into the uterine cavity. Suction is applied as the cannula is rotated. Now, you don't get out as much tissue as you would with a DNC, but you get enough, hopefully, to have a histologic diagnosis. So when the cannula is removed, the retrieved tissue is placed into formalin and sent to pathology. This is the distal end of our instrument. You can see it has an opening. We will place this into the uterine cavity. We will withdraw the piston. It will create a suction, and then you rotate this around. As the suction is created, it will aspirate into the hollow tube, hopefully endometrial tissue. You're not going to get a huge amount of it, but if you have a generalized process, you don't need to have a lot to make a diagnosis. Vulvar biopsy. This is a minor outpatient office procedure performed under local anesthesia. It is a diagnostic test looking at the histology of vulvar lesions, and any vulvar lesion of uncertain identity should be biopsied. You can either use a punch biopsy or a scalpel. The punch biopsy is very nice and convenient, and it looks like this. This is an illustration of the punch biopsy of the vulva. We use a hollow, sharp instrument like this. They come in various sizes. As you rotate it and hold it against the abnormal tissue, it will get a core, which can then be removed. If there is any bleeding from the site, you then put some silver nitrate. You don't even have to suture it closed. It will close on its own. And you have a tissue specimen. punch biopsy of the vulva. Mammography. This is an outpatient office procedure. It is performed by radiology. It can be either a screening test for breast cancer on asymptomatic women, or if a woman has a lesion which is identified by clinical examination, it can also be a diagnostic test. The risks: ionizing radiation exposure, and that's always the concern because there is radiation exposure. But it can see it is very low. It is the same as an average background radiation, which you would get in 3 months. So it's a very low level. The screening mammography, 2 views are taken of each breast. There is the craniocaudal and lateral views, and I'll show you what that looks like in just a minute. So only 2 views for screening. This is asymptomatic women who meet the criteria. If it is an indicated mammography, you may take many images, depending on what you're looking for, some under higher magnification to better visualize the target area, and the radiologist will often use a magnifying glass to better assess for any calcifications, for any abnormal areas, particularly when you're comparing previous and new images. This is done if you have a breast mass, nipple discharge, abnormal screening mammogram. The recommendations of the American Cancer Society for screening mammography is initial study, age 34, if risk factors such as breast cancer in a first-degree relative, a family history of BRCA gene. Routine screening should be done annually, starting at age 40. And those are the American Cancer Society recommendations as of 2006. Here you can see a woman who is having a mammogram done. She places her breast on this instrument, which then compresses it. The purpose of the compression is to get the tissue as thin as possible so you get maximal penetration by your beam. I went when my wife had her last mammogram, and I put my arm in to see how much compression there is, and it is a significant compression. There are 2 views which are done, a lateral and a craniocaudal view. Here you can see is a breast mass. So there are the 2 views which are done. This one shows the dense breasts with microcalcification. That is the end of gynecologic procedures.